Hi everybody, today we're going to, oh no, we're not going to talk about that. Okay, we're going to start chapter 18. This is when labor is at risk. So these are the things that can go wrong with labor or things that can happen throughout labor that we need to be prepared for. So labor at risk. So certain situations are going to put moms more at risk or fetuses more at risk. That is one of the main reasons why most people will deliver a baby in a hospital's atmosphere, just because we have the resources to be able to quickly maneuver a mom when things go south. So sometimes your midwives or your birthing centers, a lot of times if they notice anything is not going like it needs to go, or fetal heart tones aren't like they should, they will go ahead and transfer them to the hospital just in case we're getting into an event that is not going like it should. So that is one of the biggest things about a hospital. So thinking about dysfunctional labor, we call that dystocia. Dys means difficult, tocia means labor. So we got a difficult labor. Dystocia just means that labor is going progressing abnormally slow. So it's going to be because of one of our 4 P's. It's either going to be a problem with our passageway, it's going to be a problem with our passenger, maybe our passenger's too big, it's going to be a problem with our powers. Maybe we're not able to contract like we need to. Maybe mom just can't push that baby out. And the psyche. The psyche, sometimes the fear of labor can actually cause it to slow down a little bit. But many times it's not just one of these, it's multiple things that come that kind of give. It's not just one thing. It might be the passenger and the powers. It might be the passageway and the passenger. So there might be several different kinds of things that are going on there. So thinking about that, there are complications with dysfunctional labor. So it does increase the mortality rate for mom and baby. It increases the chances of infection. It increases the chances of neonatal pneumonia, uterine rupture, tends to be an increase in our C-sections. Sometimes we can get a fistula formation, which just means that because that head of the baby is in that canal on those soft tissues for such a long time, it's kind of like pressure ulcers. When there's pressure on that tissue for long periods of time, it can erode that tissue. So actually you can get an opening between the vaginal canal and the rectum, or the vaginal canal and the urethra. So those fistulas can form. We don't like to see that happen, but it can happen. So those are things that can happen if we have abnormally slow labor and the baby's head sits there for a long time. So manifestations usually occurs during that active stage. When it's going to be happen the most, it's usually going to be when that mom is 4 to 7 centimeters. It's usually going to be, or in that second stage of labor. So it's going to be an active or that second stage of labor. So the active labor would be when mom is 4 to 9 centimeters. And then second stage is when mom gets 10 centimeters and we just can't get the baby to come out. So it's really important as a nurse that you recognize when these problems occur and we notify the appropriate people. We do the appropriate interventions to prevent any complications with mom and fetus. So here's what our expected times are. So if you're thinking, I keep moving myself around here. These are the expected times. So for a primip, somebody who's never ever had a baby should be less than 20 hours. For a multip, it should be less than 14. Now, you should dilate at a certain rate, and you should, the fetus should descend at a certain rate. And you can see this is the average, what it should be. So you need to know what the average is and how quickly it should happen, because if you get a mom that kind of stalls, we need to kind of be prepared for that. What are we going to do to augmentate that labor? Augmenting labor just means that the mom is in labor on her own, but we're going to have to augment it, or we're going to have to do something to help get it going again. Usually that's going to be oxytocin, or maybe an amniotomy. So, the causes of our labor dysfunction, this is going to be with our powers. So it's going to be hypotonic or hypertonic situations. Hypotonic just means that the uterus isn't doing what it needs to be doing. It's just kind of like it's, they got contractions, but they're not doing anything to dilate or efface that cervix to get it ready. Then hypertonic means that they have way too many contractions coming one right after the other, or maybe they're lasting too long and it's causing a dysfunction. Some of these can result in a precipitous labor, especially your hypertonic. Sometimes cephalopelvic disproportion, which just means this is a problem with our passage way. So the pelvis and the baby's head are just not going to be, it's not going to come through. Or fetal malposition, that's going to be our passenger. So we got our powers here, we got our passageway, and now we got our passenger. So, the baby's just not in the right position to be able to come through that birth canal. So treatment, well, it depends on what's causing it. So we got to go back up here and we have to look at what's causing it and then determine what we're going to do for that. So if it's hypotonic, we're probably going to give them some oxytocin. We might do an amniotomy to get the labors going again. If it's hypertonic, we may actually give them a tocolytic. So we might give them terbutaline to stop their labor, because we want to stop those contractions, because maybe they're going one on top of the other and we know that that placental perfusion to the baby is not going to be enough, so we're going to stop that labor. We might have to, if it's malposition, we might have to manipulate the fetus. We might have to do a version, spin the baby around, move the baby over, put mom on the ball, the peanut ball, to get the baby to move over. So there's lots of different things. It just depends on what the cause is. So as far as nursing care, if we got mom in dysfunctional labor, it's going to be very imperative that we watch mom's vital signs, we watch her contraction patterns, and we respond accordingly with what's going on to that. We got to look at baby's response. How is baby doing with the uterine contractions? If we got a mom in hypertonic contractions, that means, or tachystoly, that means that baby is not getting the perfusion. So baby's not getting nutrients, baby's not getting oxygen, because the placenta is getting, squeezed every time. Do a thorough pain evaluation. Is it something, sometimes when moms get in extreme pain, the psyche kind of comes in. Sometimes if we give them a low dose of a narcotic, it kind of relaxes them a little bit and allows for dilation to occur. Make sure you're doing all your documentation. Notify that healthcare provider if anything slows down. Always check your bladder. A lot of times if the bladder's full, that will impede the baby from being able to descend and put more pressure to dilate that cervix, so we need to do that. So we might have to either put an indwelling catheter in, we might have to do intermittent catheterization, do lots of position changes. So malpresentation, the number one reason our babies are malpresentation is usually going to be breech presentation, or it's going to be shoulder presentation. What's going to predispose this? If you got a mom that has more than one baby in there. If you have placenta previa. Placenta previa is where the placenta goes over the top of the cervix. So usually those babies will be in a different position to be away from that placenta. They're not going to be in that head down. Hydramnios just means that they have too much fluid. So these babies have more room to roll around in there. Mom has a small pelvis. Or we've got some uterine abnormalities, and maybe the uterus is shaped a different way or something. So if the baby is breech, we're going to look at and see what type of breech it is. So is the baby a frank breech? That means that the feet are up by the head. If it's complete, baby's kind of sitting in crisscross. And if it's footling or incomplete, we might have feet presentating, out there. So how do we know a baby comes in malpresentation? One, if the mom comes in and we don't know it already, we might do Leopold's maneuver to kind of feel where baby is. We might also do an ultrasound's going to give us 100% tell us how that baby is. So we're going to look at those types of things. So how do we treat that? Usually if a baby's breech presentation, it's going to be a C-section. If we know that baby's coming in at an angle or that transverse, it's going to be a C-section. Sometimes we can do an aversion. Aversion, I think we've already talked about, it's where we spin the baby around. However, there are lots of complications that can come with that. Sometimes these babies put themselves in this position because there's something else going on. So if we have a baby that has a true knot in the cord, we have a baby that has a nuchal cord, and we spin that baby, it could cut off that circulation to the baby. So fetal heart tones are going to be very, very important right after we do that version. So we have to make sure that we have an available C-section suite in case we have to immediately take them for a C-section. So as far as nursing care, we're going to monitor these babies that are breech. We're going to do those non-stress tests, those biophysical profiles. Remember the biophysical profiles, we want them to be higher. Non-stress tests, we want it to be a positive test. We're going to position mom in different positions, have everything available that we need if we have to do that version, or if we're not going to do the version, we're going to do a C-section. pre-labor rupture of membranes. It used to be called premature rupture of membranes, but we don't really call it that anymore. It's just pre-labor rupture of membranes. So this is if a mom comes in and she's term and she has rupture of membranes. Now, sometimes it can do this before labor starts. Sometimes if it's preterm, it's before 37 weeks, and we call that preterm premature rupture of membrane. So just make sure you're aware of the different ones. In both cases, both moms are going to present with leaking of some type of fluid through the vaginal canal. So one of the biggest things that we want to look for here is infection. What has been able to ascend into that amniotic fluid that could be causing that baby infection. So once membranes eruption, infection is going to be our biggest thing that we're going to look at. So what is going to be a clinical manifestation that these moms are going to come in with? Well, they're going to either come in with a gush of water or they're going to come in with some leaking. Sometimes it's really hard to know if the leaking is urine, is it just fluids, what is it? And so we can do what we call a litmus test or a Fern test to determine that. But they might also come in with bleeding. They might say, now I feel like that the baby's head is on top of my cervix. They might not have any contractions. Many times once the water breaks, it usually throws moms into contractions, but not always. So they might not have those contractions. So how are we going to diagnose this? Again, we're going to use that Fern test, and we're going to look at the fluid and tell what it is. And then treatment, it just depends on the situation. If it is a term mom, we'll probably go ahead and induce labor. We'll probably hospitalize them. We're going to go ahead and treat them for any type of infection. If it's a mom that is early, maybe she's 28 weeks and she's just got a little bit of leaking, sometimes that amniotic fluid will go ahead and close up on its own. So a lot of times they'll go ahead and treat them for infections. Urinary tract infections or dehydration are the most common causes of throwing mom into preterm labor. So we will treat both of those causes, put mom on pelvic rest, which means that nothing comes in and out of the vagina. So they would tell them no, we would never put tampons in, no sexual intercourse, no nothing like that. And we're going to monitor that baby very, very closely. We'll do a lot of fetal surveillance. So that fetal surveillance is going to be your non-stress tests, your contraction tests. It's going to be your biophysical profiles, your ultrasounds, making sure that our babies are doing okay. So it kind of depends on what's going on, what we're going to do for that mom. Oops. Okay, so nursing care with our moms that come in pre-labor rupture membranes, just a lot of data collection. Follow our doctor's orders, make sure that we're doing what he has asked us to do. Monitor that fetus. We don't just have one person, we have two people now. We have a mom and a baby. So if you do vital signs on mom, you have to do vital signs on baby. Always be looking at those fetal heart tones. Always be assessing that to see, do we have good variability? Is everything going okay? Do we have accelerations when the baby's kicking? What's going on with that baby? Monitor for that infection. Look for any odor. Maybe mom's got fever, anything like that. If mom develops fever, she's probably going to develop tachycardia. Many times if baby has an infection inside, it's going to get tachycardia. So we're going to see that sustained heart rate over 160. Report any abnormal findings and document. Preterm labor. This is a mom that labor occurs after 19 weeks and 7 days and before the end of 37 weeks. That is our period of preterm labor. So many times preterm labor does lead to preterm birth. Biggest risk factors that we see is if mom has had preterm labor before, if she has multi-gestations in there, if there's more than one baby, if she has an infection, if she has hypertension or diabetes through that, if she has any cervical abnormalities like an incompetent cervix, anything that is going on. Maybe she's got placenta previa, anything like that that's going to throw her into preterm labor. So manifestations that mom's going to come in. These are going to be where you're going to see cervical changes. You're going to see that the bloody show is occurring. You're going to see that those contractions continue to go even when mom gets up and walks. So the quicker we can diagnose this, the better we can treat this mom. So sometimes these contractions can be painless for mom, but they feel a little bit different than what she's had in. She may have pelvic pressure. She may have vaginal pain. She may have bleeding. And membranes may or may not be ruptured, just depends on what it is. There is one diagnostic test that we can do to determine if mom's going to go into labor in the next 24 hours. It's called a fetal fibrinolectin test. And it's a swab that we do of the cervix. And if it's positive, that tells us that is more than likely that mom's going to go into labor in the next 24 hours. It is a protein that the baby gives off right before delivery. We'll also look at cervical length, and that will have to be done through an ultrasound. Treatment, it depends on the gestation. You know, the earlier the gestation, the more we're going to try to keep baby in. The later the gestation, you know, if they're 36 weeks and we just can't hold them off anymore, they may go ahead and let her deliver. But if it's 28 weeks, we're going to try to hold that baby in as long as we can, but we're going to look at all the risk factors that mom has. What risk factors does she have? If it is eclampsia, getting very, very severe, we're going to have to go ahead and deliver that baby. If it's eclampsia and it's very, very mild, we may try to hold that baby in there a little bit longer. If it's just from an infection, we're going to treat that infection and hopefully keep that baby inside. Many times, like I said, it's a urinary tract infection. Sometimes it can be a chorioamnitis infection inside. We treat that, and usually that labor will stop. So if it's dehydration, we're going to give them big filled boluses. Now, there are medications that we can give. Magnesium is one of the biggest ones that we give to stop labor. And then sometimes those moms will go home on terbutaline to keep them from going into labor. So we'll look for all those. So now we're going to look at post-term deliveries. This is where the baby has been in there longer than 42 weeks. Sometimes that it's just been a miscalculation of dates. Maybe mom didn't really know when her last menstrual period was. But post dates does increase the perinatal mortality because the placenta is usually only really good for 40 weeks. I mean, that it becomes an organ in the body, but it has a shelf life. So at 40 weeks, that placenta sometimes will start to sputter a little bit and doesn't do as well. It's kind of like an old car. It's like, okay, I'm old. I can't run as good as I used to. And so it's kind of given out. And that's kind of what our placenta does around 40 weeks. So complications. If mom has oligohydramnios, that just means, oligo means a scant amount. Hydramnios just means fluid. So if we have oligohydramnios, we don't have enough fluid. So if the fluid is low, it hasn't told the brain to start producing oxytocin. And so we don't go into labor. A lot of times after 42 weeks, these babies tend to get meconium stained because they tend to have a stool inside mom. As they're coming out, sometimes they can breathe that stool in and it gets into their lungs and they get aspiration, pneumonia from the cord, from the meconium. Cord compression. Because the baby's big. The baby has, its house is too small for it anymore, and it's pushing on that cord. Sometimes very large macrosomic babies, moms that are diabetics, shoulder dystocia, and sometimes we'll have fetal demises. These are the moms that, come in and they know they're a little bit over, and that's why after, if a mom doesn't want to be induced after 42 weeks, the doctor's going to probably have them come in very, very frequently for fetal surveillance. So how do we diagnose it? If they've had no or late prenatal care, we're going to try to determine what that fetal age is. We're going to look at anything that we can look at. Ultrasounds, do bone growth studies, anything that we can look at. If they have decreased amniotic fluid, we would be able to determine that they have oliguria. We're going to be able to see how big that baby is. Sometimes we can see if the fluid is clouded, if we do an amniocentesis, something like that. So treatment is going to be, management of this baby, frequent testing, looking at that amniotic fluid volume, induction of labor. We might even have to do an amnio infusion to kind of increase the amount of fluid inside there, especially if we have a really big baby and they're pushing on their cord. We can actually put more fluid in there to keep baby more buoyant, to keep it from smashing that umbilical cord. So as far as our care, fetal monitoring. Watch that baby's movements. Notify them if there's anything that changes. Careful monitoring of that fetal strip. We're going to be looking for those late decelerations where that placenta is telling us it is done. I am out of commission anymore. So look at that amniotic fluid. Does it have any different characteristics to it? Does it have some green fluid? Anything? Does it smell any different? Always notify your physician of anything that is going wrong. So, Intrauterine fetal demise. That's where a baby has died inside the fetus at 20 weeks or greater gestation, or has the weight of 500 grams. So we will call this a missed abortion. So the baby, for whatever reason, died inside a utero at 20 weeks or more. So it's going to be considered an abortion or a missed abortion, where we didn't quite, we didn't know that the baby was gone. So it's not the same as a fetal death from early pregnancy loss. So early pregnancy loss is just a miscarriage. This is going to be a fetal demise. So when you do your GPAL, living will be 0. They won't have had a live birth. They will have had a preterm birth. So causes, sometimes it can be fetal causes, it can be placental causes, or it can be maternal causes. But most of the time, the most common cause is a placenta abruption. So that would be, a car accident, blunt force trauma, mom falls, medications that mom is taking. Something has caused that to pull away from the wall. Hypertension, diabetes, all of those are increased risk for that placenta abruption. So clinical manifestations, mom doesn't feel any movement. So mom comes to the doctor and is like, I haven't felt my baby move. So doctor looks at it, confirms by ultrasound that there's no fetal heart rate. Then we know that we have a fetal demise. So treatment, we induce labor as soon as possible. Nursing care is the same as the mom that's in labor. The only thing a little bit different that we're going to do here is mom's going to be able to have as much medication as she wants, because we're pain medication, because we're not worried about the fetus anymore. So allow mom to have that medication if she needs it. Lots and lots of emotional support. If they have someone in their church that they want to be there, if they have a support system, allow them to take pictures, allow them to dress them, allow them to do the things that are important to them that they need to do. So other emergencies that are associated with labor and birth. So we have true emergencies that can really come very, very quickly. So the goal is for you to pick up on these and know that they're happening before the problem actually becomes severe. Get the team involved as quickly as we can so we can have a uniform movement to wherever we need to go. So communication is going to be critical. So sometimes nurses are like, well, I don't want to call the doctor just yet because I don't think that we need him yet. If you even remotely think, I would do. So amniotic fluid embolus. This is where the mom is going to come in and she's going to be in labor and she's going to have symptoms of acute respiratory distress. So she can't breathe. She can't catch her breath. She's going to have cyanosis. Blood pressure is going to plummet. And she's probably going to go into cardiac arrest very quickly. Now, it depends on how severe the amniotic fluid embolus is. But diagnosis is based pretty much on clinical symptoms and any lab studies that we do. And there's no cure. There's nothing we can do for it. We basically just have to support her vital functions and do whatever advanced life support that we may need to do. So this will be the mom that, it's just like a DVT that's broken loose and became an embolus, and it's lodged into the pulmonary artery. This is the same thing, except this is an amniotic fluid embolus, and it has vernix in it. It has all kinds of other stuff in it, so they may be a little bit bigger, and it's going to go lodge into that pulmonary artery. So many times these are fatal, but nursing care, basically responding quickly. Get that team alerted, start CPR, do any advanced CPR that needs to happen, get them hooked to oxygen, get them in that code position as much as you need. Reassure that patient that you're there with them. Shoulder dystocia, this is where the head's delivered, but we cannot get the shoulders to come out. If we don't do something very, very quickly, the baby's going to have permanent brain damage. They can also have damage in their shoulder. They can have damage up here. They can pull all of these muscles up here, and they actually have torticollis that never goes away. They can get Erb's palsy, where they can't ever move that arm very well. So one of the things that you're going to see is this thing called a turtle sign. It's where the head goes in, and then it pulls back out, and it goes back. It comes back out and pulls back in. So it's kind of like a turtle coming out of its shell. And they just can't get that baby delivered using the normal stuff that we use. So a few things that we can do is McRoberts movement and suprapubic pressure. So literally they put pressure on that shoulder from the top. So I will show you a picture of that. So here's where they actually put pressure on that shoulder and try to push that baby underneath that pubic bone and get that hand to come through. Now, mom has to have an empty bladder before delivery. So if we're going to remember that bladder can also prevent things from coming through, so we got to make sure that we straight catheter, we have an indwelling catheter. We're going to put her on a hard surface, and we're going to push to get that baby underneath. Be prepared for neonatal resuscitation. So we need to have extra people in that room during this time. Next thing is umbilical cord prolapse. Risk factors, if the baby's coming in at a weird position. Baby's coming in breech, baby's coming in at transverse lie. We got multiple babies going on in there. We got prematurity because when you got little tiny babies and we get a rupture of membranes and the baby's not engaged into that pelvic cavity, that umbilical cord has a tendency to want to come out that cervical opening because it's got a place to go. It comes out with the fluids, it comes down through there, and it's outside. Polyhydramnios. This just means that we have lots and lots of fluids, and so that fluid inside there allows more buoyancy, so it allows that cord to kind of just wrap around and go wherever it wants to go. Or a fetus that is in high station. A doctor will never do an amniotomy until the baby's head is engaged into the pelvic outlet, because that is one of the fears. If we break their water before the baby has engagement, that cord can slip underneath the baby's head. So until the baby's completely engaged, we'll never do an amniotomy. But if the membranes rupture on their own, we can have any of these things are there, that umbilical cord can prolapse. So what are you going to see? One, you may see a visible cord. You might be able to see the cord come out. Or, you might be able to reach up in there and you will feel the cord palpating. It's usually going to happen immediately after they've had an artificial rupture of membranes or a rupture of membranes on their own. And so if their membranes are ruptured while you're in the room, the first thing you need to look for is fetal heart tones and look and see if you see any type of cord. If you start seeing that fetal heart rate going up, 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 or you see it going down, 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 go up in there and see if you feel that cord or if you see that cord. If you can get the baby's head off that cord, that's what we're going to do. Vaginal exam is going to confirm this because you're going to feel that cord on top of the head. You'll be able to feel the head will be there and then the cord will be on top of it. So you're going to push that head off that cord, and you're probably going to do an immediate cesarean section. Sometimes we will actually put, amniotic fluid back in there to get the baby off the cord. We will try to push the baby back up inside there. Do not stop doing that. We may put, which I'll go to the next one, but we'll usually check those fetal heart tones immediately after that cord, after we've had an amniotomy or a spontaneous delivery. If we see it, put her in knee to chest position. So she's going to be on her knees. We want that baby to get off of that cord. So we don't want it to be with gravity. We want to prevent that. So we're going to roll mom over and put her on her knees to chest position. Get help in there as quickly as possible. You can't fix this. So you've got to get somebody in there to help. Palpate the cord for any, pulsations. Push that baby up inside there. Hold that presenting part off that baby until you can get it delivered. It's probably going to go for an emergency C-section. Uterine rupture. Uterine rupture is very, very, very rare. It doesn't happen very often. What the doctor's going to look for is where if they have had a uterine surgery before, where they've done the classic up and down vertical, the vertical incision. So sometimes we can have a uterine rupture if we've had like blunt physical trauma from intimate partner violence. Medications, if we've given them lots and lots of tocolytics and oxytocin, and we've got that cranking up there and that uterus is just really, really bearing down, we can get that uterine rupture. So clinical manifestations. What am I going to see? you're going to see a non-reassuring heart rate pattern. They're going to have pain in their abdomen. It's going to be a different pain than what they were having with their labor pains. You might be able to have pain up into their shoulder. Their blood pressure is going to start falling, and they're going to start having an increase in their pulse. That baby is all of a sudden, who is engaged now, is going to be floating up higher because it doesn't have any resistance anymore. The pressure's gone. So the baby's just going to float up higher. You may or may not see changes in the contraction pattern, so you have to be able to recognize this very quickly. Treatment is an emergency C-section. So, nursing care, recognize those signs for that uterine rupture. Sometimes, if a mom wants to have a VBAC, which is a vaginal delivery after a C-section, we will give her what we call a TOLAC, which is a trial of labor after a C-section. So TOLAC just stands for trial of labor. And so we'll trial her and see if her uterus can handle it. But be prepared for that possible rupture and be prepared to go ahead and call a C-section. So it has to be an immediate response from us to be able to take care of that. So other placental, there's other placental anomalies that we can see. One is where we have a placenta acrea. This is where we have an abnormal adherence of the placenta to the abdominal wall. This is where the placenta is not quite on the placenta wall like it should be. Or you can have a velamentous insertion of the umbilical cord where it's attached to the side, and the fetal vessels actually are separated in the membranes before they get to the placenta. So these are things that this baby's probably going to be born by a C-section. It'll probably be scheduled, and they may even take the baby a little bit early to prevent mom from going into labor on her own. Umbilical cord abnormalities. Nuchal cord just means it's wrapped around the neck. A true knot just means where the baby has been rolling around in there so much it's tied a knot in there, and the knot is getting tighter and tighter. So those are pretty much our emergencies for that chapter.